Hi, my name is Addie Duncan, and I am a math PhD student at UT Austin in Austin, Texas.
Hello, I am Alex Folk, and I am a health quality data analyst with KFMC Health Improvement Partners here in Kansas.
Hi, I am June Cocomello Hayes. I'm an applied mathematician and an assistant professor of mathematics at Bucknell University in central Pennsylvania.
My name is Amanda Landy. I'm an applied mathematician and I am an assistant teaching professor at the College of William and Mary.
A pharmacy refusal is a pharmacist's denial of a medication to a patient who has a prescription from a doctor.
Usually due to either moral or religious beliefs or objections.
When we talk about pharmacy refusals, we're not talking about instances where a prescription fill or refill is denied by the pharmacist for reasons such as missing information, hard to read or invalid prescriptions, insurance issues, or a legitimate medical concern. The history of the legal landscape of pharmacy refusals in the US starts in the early 1960s when the FDA approved the first oral contraceptive. The Catholic Church was quick to condemn this new drug, and soon after, church leaders urged Catholic pharmacists to not sell oral contraceptives except for therapeutic uses, in addition to various other contraceptive, fertility, and abortion-related drugs and apparatuses. In the 1980s and 1990s, a handful of pharmacists made headlines after they were fired for refusing to fill a prescription for oral contraceptives based on their personal, religious, and moral objections. After these instances, several pro-life pharmacy organizations put pressure on the American Pharmacists Association to adopt a so-called conscience clause, which is similar to those which arose in response to Roe v. Wade, which are meant to protect physicians who refuse to perform abortion and abortion-related procedures due to a moral objection.
So, the landscape for religiously or morally motivated pharmacy refusals is quite complex. At a federal level, a pharmacist may appeal to the Religious Freedom Restoration Act, which protects them from religion based discrimination in the workplace. And on the other hand, the patient may cite a possible gender and sex based discrimination against which they're protected under Title IX. And if the healthcare facility they're receiving care at also receives federal funds, then Section 1557 of the Affordable Care Act also protects them against discrimination. At a state level, conscience clauses allowing pharmacy refusals exist in, I believe, 11 states. Pharmacy refusals are an issue of access to care.
The history of pharmacy refusals is deeply connected to medications such as oral contraceptives and abortion medication. Access to these medications is becoming increasingly more difficult in the US, especially after the 2022 Supreme Court decision in Dobbs v. Jackson, which overturned Roe v. Wade and instigated abortion bans and restrictions across the US. Pharmacy refusals further complicate a patient's access to their prescription medication, even with a valid prescription. Patients' and pharmacists' rights when it comes to pharmacy refusals are not well known, and someone may not even be aware that their prescription medication is being withheld from them due to their pharmacist's religious or moral objection.
Anecdotal evidence suggests that effective medications include emergency contraceptives, abortion medications, and hormone replacement therapy for gender affirming care. And so we suspect that gender and sex discrimination may be at play.
This matters to me and many people that I know because myself and many of my friends are part of the LGBTQ plus community.
So this is an issue because it's equity. By the time you get to a pharmacy, you've already jumped over the hurdles of obtaining health insurance that'll cover some of the healthcare costs. You've already found a doctor that is giving you the care that you would like to receive or need to receive. And they've already prescribed to you a medical treatment plan that extends beyond the doctor's offices. And so when you get to a pharmacy, you don't think, oh man, this is when it's going to stop. This is when I'm going to stop receiving my care. It's the last stop on your treatment to getting the treatment that you need. And so it's important to know that you can be refused at this last stop. You could be told that you're not going to receive this medicine. This pharmacy refusal lab is working on many different aspects of this problem. One of the aspects of pharmacy refusals that we're doing is just trying to aggregate and centralize all the policies that exist. So the conscientious clause, as was mentioned earlier, is listed in many different places. It has many different tiers. So we're centralizing this information on policies, rules, and regulations so that folks can go to one stop and find out all the information they need before or after walking into a pharmacy.
So what are we doing about this? What is the lab doing about this? Some people in the lab are working on collecting and creating data to understand what are the risk factors for refusals, such as patient's demographic, but also what kind of medications. And this is so we can understand if certain groups are disproportionately affected.
Initially, we were interested in collecting data about pharmacy refusal incidents from online sources such as news articles, legal documents, and social media posts. The goal is to build a database of incidents so that we can answer demographic questions about pharmacy refusals and better understand the prevalence of these incidents. Later on, we realized that the information available publicly was not sufficient, and so now we're trying to collect additional information about incidents through an anonymous online survey. If you or someone you know may have experienced a pharmacy refusal, you can respond to our anonymous survey, which you can find on the Pharmacy Refusal Lab page at qsideinstitute.org.
Alex, Amanda, and myself are focusing on analyzing gaps in pharmacy access that may arise if a pharmacy were to refuse to fill a prescription. And so I'm in Pennsylvania, so say that 1 every 10 pharmacies in Philly were to refuse to fill a particular prescription. Then we may ask how many people will lose access to pharmacies within, 20 minutes of their home in terms of traveling distance. Are certain areas of the city more at risk than others? What kind of people live there? So are there demographics that are more affected than others by pharmacy refusals?
I specifically am working on the code that we use for the topological data analysis portion of this work, though I have also been involved in writing and reviewing, and I'm sure I'll be doing more of that as the work progresses.
So broadly speaking, our goal is to develop mathematical tools to answer questions like this.
Thank you.
Thank you.
That should be all.